I've been asked to look at two topics, and I'm hoping to be able to get through both of them. But I'm going to go through this one first because I think this is probably where you wanted to start off from. So we're going to talk about hospital deaths and the coroner system. Just to give you an idea of deaths in Ontario. This is all deaths, not just in hospital, but just give you some idea of what the coroners do and what the volume is like in that. Roughly, there are 80,000 deaths in Ontario per year. Of those 80,000 deaths, 20,000 of them are coroners' cases. So approximately 1 in 4 are coroners' cases, 25%. And of those 20,000 cases, they break down to 15,000 are natural deaths, 3,000 are accidental, 1,100 are deemed suicide, 500 are deemed undetermined, and only 175 to 200, thank goodness, are homicides. Interestingly enough, we do 6,500 medical legal autopsies. So if you look at the 20,000 deaths that we do, that we investigate, only a third require post-mortem examination. What coroners do and what coroners expect physicians and other people in the public to do are legislated by the Coroners Act of Ontario. And it was last amended in 2008 and proclaimed in 2009. It is a piece of legislation that regulates what I do as a coroner, and it is a piece of legislation that regulates what other people should do in contacting a coroner. And it's a reasonable piece of legislation to read if you have an opportunity at some time. Even people who use it all the time, like myself, I keep a copy of it handy with me at all times. It's actually sitting in my little bag behind me, so I can refer to it because I can't remember everything. But it is what guides and governs what goes on. From our point of view for today, one of the things I want to talk about is Section 10 of the Coroners Act. Section 10 of the Coroners Act defines what types of deaths are considered to be coroners' cases and are reportable to coroners. And this is what it says. Every person who has reason to believe that the deceased person has died of violence or misadventure, negligence, misconduct, malpractice, by unfair means, whatever that means. None of us have any idea what by unfair means means. We tried to get it out of the Act when it was amended in 2008. However, it stayed in there, and I have no idea what it means. During pregnancy or following pregnancy in circumstances that might be attributable thereto, suddenly and unexpectedly, and the important word in D is and. We all die unexpectedly. None of us put in our day timer that at 10 o'clock on the 8th of December I'm going to die. So it suddenly and unexpectedly. From a disease or sickness from which they are not treated by a legally qualified medical practitioner, from any cause other than disease, and then the obvious catch one, which every act in Ontario has, under such circumstances as required, as may be required. And Section 1 also says they shall immediately notify a coroner or a police officer of the facts and circumstances relating to the death. Also, people who are residents of certain institutions are reported to coroners, charitable institutions, child residences, group homes under what used to be called the Disabilities Act, but now because disabilities is a bad word, it's under the Services and Support to Promote the Social Inclusion of Persons with Developmental Disabilities Act. Try saying that in one breath. And psychiatric facilities. These deaths are to be reported to the coroner. However, there is a bit of a time limit of 31 days, generally speaking, except if the death falls under Section 10 in another instance, such as someone from a group home falls, fractures their hip, is in hospital, and then dies of a myocardial infarction 6 weeks later. That would be reportable to a coroner because the process that started this whole thing was an accident, and that's reportable. So it's difficult to remember all the parts of Section 10, so put it in a nutshell. All non-natural deaths. So accidents, suicides, homicides, and cases where you have absolutely no idea what the manner of death is, those should be reported to a coroner, including deaths that follow remote injuries. There is no statute of limitations to accidents or injuries. The most famous example that I can give you is Christopher Reeves, the original Superman in the movies. Christopher Reeves' death, if it had occurred in Ontario, would have been a coroner's investigation. Why? Christopher Reeves died of urosepsis. He developed urosepsis because he had an indwelling catheter. He had an indwelling catheter because he had a spinal cord injury. He had a spinal cord injury because he fell off a horse some 10 to 15 years before he died. The reason for his death goes back to that injury. Christopher Reeves' death, although was due to urosepsis, which is natural in its context by itself, is an accidental death, because what led to that, his death, was an accident. So natural deaths with potential issues, family issues, or physician issues, or just something doesn't sound right. All deaths in custody, someone who is in the custody of the police or at Elgin Middlesex Detention Center here, for example, those are reportable to a coroner. Generally speaking, we sort of recommend that all deaths under the age of children under the age of 2, and usually most pediatric deaths under the age of 18 should probably be run by a coroner just to be sure. Some deaths in long-term care facilities also need to be notified. Coroner needs to be notified. Some other parts of the Coroners Act which are important. Section 11, which states that no one shall interfere with or alter the body in any way until directed so by the coroner. We'll come back to this with the example that we had a little earlier tonight, or this morning. Also, Section 16 of the Coroners Act says that no person shall knowingly obstruct or hinder or interfere with coroner doing his job. Because Section 55 says that any person who contravenes Section 10, which is failure to inform, Section 11, which is alter the body, Section 13, which is to transport a body outside of Ontario, which you people wouldn't be doing anyway, and Section 16, interfering with the coroner, is guilty of an offense and on conviction is liable to a fine of not more than $1,000 or imprisonment of a term not more than 6 months, or both. This is quite serious. So how do you call a coroner? First off, you call the coroner's dispatch. Usually in the emergency department, they have the number of what the coroner's dispatch is. That number will change in the new year. We're going to be going to a provincial dispatch system, probably in the new year. And there will be a 1-866 number for the whole province. When that gets rolled out, the hospitals will be informed with some lead time. Should provide some information to the dispatcher about the deceased, such as the demographic data, what happened, some general background information, and yourself, who you are, and your contact information so that the coroner can get back to you. Coroner will call back and get some more information from you to discuss the case to determine whether or not the case is a coroner's case or not. It is your duty to notify the coroner. It is the coroner who decides whether or not the death fits Section 10 of the Coroners Act. So the coroner may tell you, thank you very much, this death doesn't fit Section 10 criteria of the Coroners Act. You can go ahead, sign the death certificate, and get things underway. Or you may say, fine, thank you. I'll be there as soon as I can. So, when a person dies in hospital, how do I know if it's a coroner's case? If it's caused by an accident, or the accident precipitated the admission, were drugs or alcohol involved? Is the death sudden and unexpected? Is the death caused by violence of any kind? Is the death due to a self-inflicted injury or overdose? Is there any negligence or mistreatment in this death? Are there any family issues or family members expressing concerns about care or other issues? Did the death occur in any phase of pregnancy? Is the patient from an institution that may require reporting of the death? Were they a psychiatric patient, or in custody, or under child or children's aid care? Children's aid children are coroner's cases. If the Children's Aid Society has an open file and it hasn't been closed for longer than 12 months. And that's a memorandum of understanding that the coroner's office has with the Children's Aid Societies of Ontario. If you are not sure, then call. Bottom line. If you're not sure, you don't know exactly, call and talk it over with the coroner. Certainly it's much better to call then as opposed to get a call later on why didn't we get the call about this case. There are some myths about calling coroners that I want to try to just let you think about. There is no such thing as a 24-hour rule. I don't know how this urban myth started. I have no idea why it's being perpetuated, but every so often we get calls about this 75-year-old lady came into the hospital with an acute myocardial infarct. She had ST elevations all over the yin-yang, or troponins were elevated, and she dies 5 hours after she gets to the hospital. Why did you call? Well, she died within 24 hours of arriving in the hospital. It doesn't exist. I don't know why it's there, but it still sometimes happens. So there's no such thing as a 24-hour rule. There's no such thing as a transfer rule. Just because a person gets transferred from one healthcare facility to another healthcare facility, or one hospital from another, does not necessarily make that a coroner's case. Sudden and unexpected in people with known pathological processes. Well, Mr. Coroner, I mean, this lady, she's got bad coronary artery disease. She smokes like a chimney. She's got a family history of early cardiac death. she was at home with a party, and all of a sudden she was witness just to collapse on the floor. You know, I don't know why she died. I'm not a mind reader. You know, maybe she died of something nefarious or something of that nature. Again, this is not sudden and unexpected. So, before death is pronounced, you as emergency physicians, what do? Before death is pronounced, you do everything that you have to. But try to preserve evidence, because we may not be sure initially what we're dealing with. So please try not to put tubes into body cavities through holes. I know it's a wonderful thing. Hey, I've already got a hole. I can stick that chest tube in through the hole. It really creates problems. So try not, don't put tubes through holes that are already there, or alter them. Don't incorporate wounds into incisions. Sometimes you can't help it. That's fine. Make sure you document it so that we know, and so that the pathologist knows when they're doing post-mortem examination. Don't throw anything away. Document everything that you do as accurately as possible, as soon as possible, while it's still fresh in your mind. After death is pronounced, what do? You stop doing. Do not disturb anything or allow anyone else to disturb anything. And that's difficult at times, and I recognize that. Record what you observed. Record what you did. Procedures, drugs. If it comes to doing a tox screen, which is common certainly on all homicides and in most accidents, if we find something that we weren't expecting, and then we started asking questions, and lo and behold, it was something that you gave in the emergency department, we'd like to know about that beforehand so that we've got some idea of what's happening. And share your concerns with other members, with the coroner, with other members of the team. So do not be a member of the EET, the evidence elimination team. Why is this important? It's important because things like blood spatter, semen and other fluids, fibers, gunshot residue, fingerprints, ligatures, all these things are important investigative tools to help us understand what happened and possibly related to the criminal justice system. And any questions on this part of things?
We pronounce a lot of people in the field through EMS talking to us on the phone. Do we have any legal responsibility to notify coroners in that case, or can we assume that the police or EMS are notifying the coroner? These would be patients that we never see.
Generally speaking, EMS or the police notify us, and most of the time, at least in the reports that I get, when there's been a field pronouncement, it's usually natural deaths that you do the field pronouncement, right? It's well, except for accidents and accidents and things of that nature. Those ones are usually slam dunks, and the police give us a shout. If it sounds natural and there doesn't seem to be any suspicions, it fits Section 10 criteria, then or doesn't fit Section 10 criteria, then you don't really need to notify. Generally speaking, either the EMS or the police who are on the scene notify the coroner's office of that because they're on the scene. So it's usually, so I'm not aware of any deaths where that hasn't happened, where the notification hasn't occurred. So it's usually by EMS or the police that are on the scene.
I have two questions. One, what's a reasonable amount of time in which we can expect a coroner to respond to our phone calls?
That varies.
Because sometimes it's quite sizable in, I know the person's dead, but there is sometimes a need to get on with things, tying up a person in the emerge for extended periods of time. I've found sometimes it's in the range of sometimes even 3 hours before you get a phone call back.
It can be. Coroners in the office in the province of Ontario are not salaried. This is on top of their normal activities. If you are a coroner and you're in the OR providing anesthesia for a list, you're not going to be able to get out until you're finished your list. That's our reality. We try to get there as soon as we can, but sometimes it's difficult to get to a case. Sometimes we have to prioritize. If you've got 3 or 4 cases on the go, which one you got to try to prioritize which one you go to first, and then continue on. We try to get there as soon as we can. Certainly, one of the things that one can do is communicate with the coroner. To sort of say, they may say, it's going to be an hour or so before I get there, and you say, well, the person is in our trauma bay. Can we move? And you may be able to negotiate with the coroner. Okay.
But I find sometimes you can't even get a hold of them to talk to them.
You should be able to. They should be able to get in touch with. Somebody should be able to talk to them because they should be calling back to find out what's going on.
Is there a call roster? Is someone on call?
No.
No, that's a problem that I've encountered too, where they tell me no one's on call, we just keep going down the list until we find someone.
That's correct.
Like, that's a ludicrous system.
Unfortunately, that's a system that is in most of Ontario, because the volume is not there, and the coroners have other things to do.
Sure, but I'm sure that on holiday long weekends, they all have other things to do too, right? Like, that doesn't sound like a sustainable system to me.
In London, there is a coroner on call on the weekends to cover the city of London. In other places in the province, there are great distances for coroners. Not every community in Ontario has a coroner, and if you even consider Northern Ontario and Northwestern Ontario, there is great distances between coroners. Even in Southwestern Ontario, there are areas and pockets where the coroners have to travel many miles to get there. It's not a perfect system. We try to make it as good as we can, but we recognize that there are gaps.
The other question I had is, I've had a bunch of death certificates returned to me recently, including one yesterday, and sometimes they want me to be more clear in how I filled it out. But sometimes these are people, death certificates from 2 or 3 years ago. Mm-hmm. Yesterday's was from 3 years ago. I thought, well, maybe I can be more clear because the autopsy's back. But then when I looked at it, there's no autopsy. And what they were upset about was I wrote out of hospital cardiac arrest. And they said, you need to be very specific about the cause of death. And so I find like I'm basically making stuff up. Okay, MI. And I don't know if she died of an MI. She had an out-of-hospital witnessed cardiac arrest. I just felt like I'm being coerced into making something up here. And that's not the first time I've experienced that. It seems like I'm getting a lot of death certificates back from the regional office or whatever.
From the Registrar General's office. It has nothing to do with us.
And they want specifics.
They want a disease.
Yeah,
cardiac. All of us die of cardiac arrest. All of us die of respiratory failure. That's a mode of death. That's not a cause of death.
But on the one hand, we see stats in studies that say physicians are not very good at knowing the cause of death. But on the other hand, they want me to make it up.
Unfortunately, that's the States.
Oh, I think we're bad too here.
We are bad here. we are bad here, but the standard of proof for a medical certificate of death in the province of Ontario is your best educated guess. That's why only physicians and nurses of extended class can certify death in the province of Ontario, because you have medical knowledge, as opposed to some jurisdictions where an 18-year-old who gets elected by the people in his county signs all the death certificates. Okay? The standard of proof is the balance of probabilities. What's the most likely? In a 65-year-old, otherwise healthy male who drops dead, on the balance of probabilities, even though they have no known history, on the balance of probabilities, that's a cardiovascular event, and they died of myocardial infarction or coronary artery disease or ischemic heart disease, however you want to phrase that, on the balance of probabilities. And in fact, if you look at the literature, you're almost safe on the balance of probabilities to bring that down almost to 45 in males at the present time.
I'm happy to make educated guesses.
That's all
but I
that's
don't
asked.
want people getting angry with me or coming back at me saying, well, how do you know it was a myocardial infarction? I just feel like we're being put between a rock and a hard place.
No, you can say, in my professional opinion, that's what they died of, and that's all that's being asked for filling out a medical certificate of death.
Is there still the index cases from the nursing homes? Sort of those every 10th case from a nursing home where you had to call?
That's going to be changing. We used to have every 10th death of a nursing home resident. That was a coroner's investigation. All the deaths have to be reported to the coroner, but every 10th one is a coroner's investigation. On recent legal interpretation of the Act, it will basically change to the only nursing home patients who are resident in the nursing home. So actually that they're in the nursing home. If they die in the hospital, they aren't necessarily counted as one of the 10th. Now there may be other reasons for an investigation, like it may have been related to a fall, or it may have been there may have been some questions as far as care at the nursing home and that's concerned, or they may have fit into the Coroner's Act by another reason, but just basically being the 10th death on its own in hospital of a nursing home resident will not necessarily, will not necessarily mean that that's a coroner's case by itself. Back at the back.
So I don't know if I misunderstood. Sorry, the fat diabetic smoking partier, that is a coroner's case who just plopped down dead, or is not a coroner's case?
All things being equal, it would not be a coroner's case.
That's not sudden and unexpected. I mean,
it may be sudden, but it's not unexpected.
Well, we're all expected to die, like you said.
Right.
But because they're 50 and diabetic and smoking while they're dancing, that's expected. Really? Come on.
Well, it's 50 now. I don't have, as I said, when in doubt, call the coroner, and then the coroner can look at all the information and say, yes, this is a coroner's case, or no, this isn't a coroner's case.
And secondly, following up on John Gibson's case, question, I guess, I mean, I would think this depends a lot on physicians and their obviously integrity, but our problem is that, if we don't feel we did a good job, or maybe we screwed up, maybe it's not in our best interest to have this be a coroner's case. So would you guys do some 1%, 2% where we're going to investigate anyways? And this does come up because I reviewed an M&M case in September, which I talked to you about, and clearly this was sudden and unexpected. clearly. And there, even in the chart was written, call a coroner, not a coroner's case. And then only because I went and followed up with the patient the next day, I said, this is ridiculous. And called you guys, and then all of a sudden they say, oh, well, maybe it is. So I don't know what happened in that initial coroner versus physician talk, but clearly it was felt not to be a coroner's case, and then clearly the next day it was felt to be a coroner's case. So, you know, I guess it's to avoid what maybe happened in England, where that, you know, physician was often a little old ladies for joy. So I just don't know if you guys have something built in like that or not.
Basically, we can only basically go on the information that we receive. And that's why, you know, if anyone basically at any time has some concerns or suspicions, then they can certainly notify a coroner. Sometimes, you know, we do find cases months after they've occurred, sometimes years after they occur, when the medical certificate of death gets reviewed at the Office of the Registrar General, and at the bottom of it, that, you know, they've got cardiac arrest due to myocardial infarction, and then at the very bottom in section 2 of conditions associated, they've gotten a fall and broken hip. That's coroner. That, you know, that was a coroner's case. It didn't get it got missed. It happens, and then we have to investigate again. So, you know, if someone has a reason to believe, there's no time frame on that. You know, I have a reason to believe that something that there was some negligence or something like that here. Then it can be the coroner can be notified. But again, it's up to the coroner with the information that they're provided to determine whether or not it satisfies Section 10.
I'm just saying, you know, there's been quite a few studies down the States now coming out saying, you know, how we probably cause a lot of deaths in hospitals, you know, by mistakes and errors, and it's always in our interest to minimize those. I would just think it would be, you know, it would be in the public's best interest that we take 1 out of 50 or 1 out of 100 and just, you know, do an autopsy and see what we find.
Mm-hmm. And that may be part of a quality assurance program within a hospital, but maybe not necessarily involving the coroner system.
I have a question about the dispatch center that is starting up in terms of, you know, Dr. Anderson's concerns about contacting. How is that going to change now that there's like going to be a 1-800 number or whatever with the dispatch center in terms of, you know, getting the coroner to respond promptly? The coroner will still try to get to a scene in a timely manner. This will be all done centrally, and so the system will have, because it's going to be done centrally in our office, then we will have access to the information in terms of timelines and things of that nature that we don't have now. There is no provincial dispatch. We have, as an office, we don't have timelines provided to us because it's being done by private companies. And so we don't know what's going on in that point of view. One of the things that provincial dispatch will do, seeing as it's going to be within house, is that we'll be able to track these things, and we'll see what's happening with that.
Can you speak to the 5-month-old case? We had a case here not long ago where the child came in, arrested, the parents showed up, and it was probably an hour or more before the coroner arrived and we could get the mom and dad in with the baby, and it was quite distressing for everybody. Do you have any suggestions, you know, for that situation, or anything we can do to help?
These are difficult. We try to get to these as soon as we can, but as I said, there are all sorts of factors that can get in the way with this. Section 11 of the Coroners Act says no one is to interfere with.
And certainly in child cases and in infant deaths, that's difficult. There should be no time when members of family are left alone with the infant in the room. So nurse should be, or some person at the hospital should be with the family if and when they go into the room, and remain with them. Police force should be called fairly quickly to assist you and assist the coroner with basically scene preservation. Police have certainly some training in terms of dealing with families in these very difficult situations. Certainly with this case, we don't know what happened. This could be a homicide. This could be an accidental death. This could be a natural death. We don't know. And in order to get the best information to answer those questions, we need to have things as pristine as we can. So, mother asked to hold the baby. We should certainly look at trying to discourage holding the baby. I know it's hard. I'm not saying that this is all easy. But that's what we need to try to do so that evidence is preserved and we don't get extraneous evidence there that wasn't there as part of the death process that will interfere with the investigation. Tubes, IVs need to stay where they are. Certainly, there can be discussions with the coroner in terms of equipment and leads and things of that nature, and you can certainly go by the coroner's direction. As Section 11 said, not to disturb unless permitted or unless it's been discussed with the coroner first off. So monitor the leads themselves. The leads themselves can certainly be unclipped as far as the electronics are concerned, but where the leads are on the body should stay where they are.
Yeah, I mean, in this case, the coroner said, you know, the mom, it was about an hour to get the coroner there, so we had the mom in one room, the kid in another room, the police wouldn't let her in. And then when they got there, they hold the kid for a minute, and that's it. I thought that was quite cruel, and they, you know, I can't imagine that if you have a policeman and you wrap the kid in a blanket that you're going to destroy any evidence. You know, the mom just gets to hold the baby wrapped in a blanket. But it was probably the worst thing I've seen in my career, was that day.
Yeah, you'd be surprised what evidence can go missing. That's the unfortunate fact.
But with the policeman standing there, and the kid wrapped in
well, there's got to be some give and take. Yeah. I'm not going to argue with that.
I mean, my frustration would be on cases, not like that exactly, but some cases, you can't get a hold of the coroner to discuss the situation even, to say, can the mom hold the baby? And so you're seen in this very conflicted position.
Let it go, Keeler. Let it go now.
Sorry?
I told him to let it go.
So we need to look at that aspect of it. Is it going to be perfect all the time? No. That's the ideal. We want to try to do that.
If the parents were in the room during the resuscitation and the police weren't there, I mean, we probably would have just given the kid to the mom, you know, right after if they passed away, you know, with families in during resuscitations now. So because they didn't make it in time, they sort of got locked out. You know,
Yep. Again, ideally, to try to discourage that. I know it's hard, but again, and particularly in a scenario like this, we don't know what happened, and injuries can occur shortly after death that are totally innocent, that then might lead investigators down a wrong path, or something may get changed to lead the investigators down another path. It's not perfect. Death is not easy for anybody at any age, and certainly young people. It's tough, and I would certainly understand that it is an emotionally difficult for everyone. And if we can try to maintain the scene as best as we can, that's our goal. In terms of so.
If I could just make a comment. I'm a pediatric emergency physician and chief of the city here, and Dave emailed me immediately after that case. And when this was brought in, because prior to, I think, 2008 or 5 or something in there, we used to commonly be able to hand the patient without a lot of context. And of course, then the pediatric death review committee got formed, and then they're on this evangelic route to prove that all deaths caused to children are the result of parental abuse, which may or may not be true. But one of the things that makes it very difficult is, the trauma that we, as physicians, I think the conflict for us as physicians, and I know you're a physician, is, watching a family go through a terrible scenario of grief, being unable to have any contact with their child in probably one of the most devastating moments of their lives. I've found most coroners are pretty reasonable. If there's a police constable there, that they'll allow the parent to hold the child. Sometimes they'll ask the parent to wear gloves. Obviously the child needs to be bundled. None of the things can be left out, or they'll let the parent at least come to the bedside to be beside the child. But I would request that somebody take a very serious look, and I realize it's got to do with part of the act, that whatever section 11 or 12 that you talked about. But I think there has to be some, within the course of all of this, there has to be some degree of humanity and well-being for both the parent. I don't know if you're a parent or not, but as a parent, I can't fathom losing a child. I think that's got to be probably one of the worst things that can happen to you. But I really do find it a very offensive component to the Coroners Act as a healthcare provider. I think and I know that, your previous colleague, Dr. Wilson, came to us as pediatric emergency physicians and produced a lot of evidence showing, there's a lot of maltreatment that does get picked up, that may not have been picked up. But I still have significant concerns about our impact on families and their overall well-being. And I think there's some significant literature out there that would support what we do at the time of death is very important towards the overall long-term healing and ability of families to move on from the death of a child.
I'm not going to argue with what you said, and I think the important thing is that if that is going to occur, that there is somebody there with the family, as opposed to no one being there, including a nurse or something like that, so that there can be some documentation. I think that's that is important. So I think that certainly it can occur, and I think what you were talking about with the gloves and all those types of precautions, I think, are reasonable things to expect, including having somebody there, either police officer or nurse or physician or whoever who can document what's going on.
Is that something you guys can put out though, as like to all the coroners, or make it a a practice? Because that's not what happened that day. On direction from the coroner.
Okay. Thanks for that.